Dr. DeVosa graduated from the medical school at the University of Milan and did his postgraduate medical training in the United States. He completed an internship at the University of Minnesota in the Twin Cities and then moved to Washington University School of Medicine in St. Louis for his specialty training in neurology. While at Washington University, he also pursued his subspecialized training in behavioral neurology at the university's Alzheimer's Disease Research Center and Neuroimaging Laboratory. Now, Dr. DeVosa is a lecturer at Bangor University School of Psychology, and his clinical interests are in degenerative disorders of the central nervous system and the cognitive and behavioral effects of neurological diseases. Dr. DeVosa has also asked me to mention that while he is an adult neurologist certified by the American Board of Psychology and Neurology, he's not yet licensed in the United Kingdom, and he apologizes that he can't see people for appointments. However, I'm sure you will get a lot of very good information that you would like to follow up and know more about. So I present for you Dr. DeVosa. Thank you.
Thank you, Donna. Thank you, Donna. So I'm going to tell you about lifetime risk factors for age-related cognitive decline and dementia. The reason why this is an important topic is that dementia robs us of what makes us human, namely our ability to think and remember. And it places great strain on stricken individuals and especially members of their family. So obviously the question arises of how can we prevent dementia, how can we treat dementia, how can we diminish the burden of this terrible disorder on ourselves. In order to address those questions, I will mainly review studies, observational studies, that have looked at what are the factors that are related to the risk of developing dementia. Those studies are important because they indicate possible causative associations between early factors in life and the risk of developing dementia later on. However, they cannot establish beyond doubt the existence of a causative effect between identified risk factors and dementia. In order to do so, namely in order to understand and to know that, for example, changing those factors actually decreases the risk of developing dementia, you need to run what are called clinical trials, namely actual experiments on patients in which you compare treatment to non-treatment in order to establish the efficacy of an intervention. Unfortunately, there is very little data regarding interventions, and therefore there is no established intervention yet that we use in order to prevent dementia at the present time. Now, the likelihood is that this will change soon, but how soon I cannot tell. So let's start. Good. So let me define the terms that I shall be using during this talk, and these are dementia, healthy aging, and mild cognitive impairment. What is dementia? Dementia is a syndrome characterized by loss of mental abilities severe enough to cause impaired capacity to function independently. Healthy aging, on the other hand, defines cognitive changes normally associated with aging, but in the absence of disease. Mild cognitive impairment is a condition between healthy aging and dementia, associated with an isolated cognitive deficit affecting short-term memory. This deficit is not severe enough to disrupt function. MCI, namely mild cognitive impairment, is a condition associated with an increased risk of developing dementia. And some believe that MCI is actually very early dementia. So, what are the cognitive changes that accompany healthy aging, normal aging? Well, there are two main changes with aging that affect our mental abilities. First change is a good change. Semantic memory, namely the mental compendium of factual information, for example, who was the prime minister during the Second World War, and conceptual information, such as the knowledge that following every boom there is a bust, increases with age, and continues to increase also in old age. On the other hand, speed of psychological processes instead declines with age. That is, it takes longer to perform a certain mental operation in an older individual than in a younger individual, such as, for example, remembering what you had for breakfast. If you're an older individual, it may take you longer to perform that operation than in a younger individual. But if you are healthy, you should eventually be able to do so. So what are the earliest cognitive changes in not so healthy aging? Well, what you observe is an impairment mainly. It's an impairment in short-term memory, namely remembering recent events, where one has placed keys, the purse, the wallet, etc. And difficulty learning new tasks, such as operating the new DVD player or the microwave. As clinicians, we are faced with a problem of distinguishing dementia versus healthy aging. And when the cognitive impairment is marked, that is, when the patient that we examine has dementia, the distinction with the healthy aging is obvious. You don't need to be medically trained to understand that there is something wrong with the patient. Early mild cognitive impairment is defined, on the other hand, by an isolated, by consistent short-term memory problem, and is associated with an increased risk of developing dementia. As clinicians, we sometimes are in a position or in a situation where we may want to determine whether a patient is affected by mild cognitive impairment, because having mild cognitive impairment confers a higher risk of eventually becoming demented. There is really no intervention at the present time from stopping that from happening. However, in major academic and clinical centers, frequently these are the patients who are actually enrolled in clinical trials and studies aimed at finding new therapies. Because this is a particular stage where we think that early intervention may actually provide the best opportunity for stopping or maybe reversing the disease. As I was telling you before, short-term memory changes in healthy aging are marked by a relative deficit only when a response is required quickly. In other words, given enough time, healthy older adults are generally as accurate as young adults. Let me give you an example of dementia, patient who actually developed dementia. So just to give you a sense of what we are talking about. A 73-year-old woman was brought to the neurologist office by her brother because of a 3-year history of memory impairment. She had completed high school and worked in a clerical position until her retirement. She had lived alone and maintained her home and financial affairs since the death of her husband. The brother had begun to notice gradually worsening memory impairment and difficulty finding words. But the patient became angry at the suggestion that she may have a progressive impairment. Others in the family had noted decline in housekeeping and financial affairs, but she had no complaints. When she came to the doctor's office, she was a well-groomed woman who was alert and friendly. Her speech was highly abnormal, with a tendency to use vague reference, such as things and stuff. She was able to provide her name, but when asked about her current age, she said, "I don't know, about 8, I think." She incorrectly stated her birth month, but then became aware of this. Given 3 choices, she was able to give the correct month. She was unable to give the year of her birth, the current year, or the name of the current prime minister. On formal testing, she scored well below average in all cognitive domains. She tended to repeat herself. So you can see the picture of a patient affected by dementia. This person shows deficits in several areas of her cognition. Her memory is impaired, her language is impaired, her ability to tell the time and where she is may be impaired. Hence, she has evidence of, again, impairment in several areas of her cognition. Furthermore, this impairment affects her ability to live independently. As you heard, she is not able to watch after her finances as well as she used to, and she's not doing a good job at home at keeping the house in order. Hence, evidence that her ability to function independently is compromised. These are the main features that define dementia, and I hope that the case has made that clear. How common is dementia? Well, unfortunately, very common in older individuals. Large numbers of epidemiological studies estimate that among people between 60 and 65 years of age, about 1% have dementia. The proportion of individuals with dementia doubles every 5 years. Namely, in people between 65 and 70 years of age, the proportion of individuals with dementia is 2%, and between 70 and 75, 4%, and so forth. Eventually, 50% of individuals 90 years of age and older have dementia. What about the frequency of mild cognitive impairment? And I apologize for the misspelling. Well, that is the stage between, let's say, healthy aging and dementia. The data are less good than for dementia. However, initial observations suggest that about 5% of individuals between the age of 60 and 75 years of age have mild cognitive impairment. That is twice as many as those with dementia. These are the individuals most at risk for developing dementia later in life. This is a kind of idealized graph that shows the proportion of individuals affected by dementia as a function of age. So this is age, and this is the proportion of individuals that are affected by dementia, and specifically by dementia of the Alzheimer's type. There are two main features that you should be able to extract from the figure. First is that the proportion of individuals affected by dementia increases continuously as a function of age. There has been a debate whether eventually after age 90, the proportion of individuals affected by dementia stabilizes, but that does not appear to be the case. Secondly, the proportion of women affected by dementia is somewhat greater than the proportion of men affected by dementia. And a number of explanations have been offered for that difference. Among the main one is that hormonal changes associated with menopause affect women disproportionately more than men, who also go through a similar hormonal change, which is nevertheless quite less marked. At some point, the proposal was made that the relative deficiency of estrogen hormones, principally, if reversed, could lead to a decrease in the incidence of dementia in women. Eventually, those trials have been carried out and have proven to be negative. Namely, estrogen supplementation in women does not change the chances of developing dementia, and actually has a number of ill effects on people's health. So what causes dementia? I just mentioned Alzheimer's disease. Well, dementia is caused primarily by neurodegenerative and vascular atherosclerotic disease affecting the brain. It is estimated that about 60% of people with dementia have Alzheimer's disease. So Alzheimer's disease is actually the major cause of dementia in older individuals. About 30% of people with dementia have vascular dementia. That is dementia that follows a stroke. When looking at this number, it's useful to take somewhat of a historical perspective. Until 30 years ago, it was common to attribute dementia in old age, namely senile dementia, to stiff vessels and small strokes. And dementia in young adults, what is called presenile dementia, to Alzheimer's disease. Indeed, Dr. Alzheimer himself described the condition for the first time in a patient who developed the problem in her early 50s, namely a patient with presenile dementia. More recently, it has been recognized that Alzheimer's disease is found in the brains of most older individuals with dementia. Currently, the hypothesis is that neurodegeneration due to Alzheimer's disease and disruption of blood supply to the brain, that is, vascular disease, contribute both to dementia in most patients. Namely, that it's not like some patients have Alzheimer's disease and other patients have vascular dementia, but rather in most patients you will find a combination of both pathologies. A very active area of investigation is whether and how vascular factors may worsen Alzheimer's disease and vice versa, namely how Alzheimer's disease pathology may actually impair blood flow to the brain, as there is evidence for that as well. So let's get now to the risk factors for dementia. There are several risk factors for age-related dementia that are both biological in nature and psychosocial. First one is your genetic makeup, your family history, the presence of vascular risk factors such as high blood pressure. Also, early life intelligence and cognitive abilities affect the likelihood of developing dementia in old age. Socioeconomic status, how educated you are, how complex was the job that you held before you retired, and lifestyle factors. I will now review each of those and tell you what we know about them. Genetic risk factors. Well, 5% of individuals with dementia have a genetic disorder. That is, they carry a mutated gene that invariably leads to dementia early in life. 95% of individuals, on the other hand, stricken by dementia, do not have a genetic form of the disease, and they're said to have sporadic dementia. However, genetic influences on the risk of developing sporadic dementia have been noted, mainly for genes that code for proteins involved in the metabolism of cholesterol. The nature of this association between fat metabolism, lipid metabolism, and risk of dementia remains unclear. There are also familiar risk factors. Having a first-degree relative with dementia is a risk factor for dementia. If you have a brother, a sister, a father or a mother who suffered from dementia or is suffering from dementia, you have a somewhat increased risk of getting dementia yourself. Whether this risk depends on genetic and/or environmental factors remains unknown, since the risk of dementia due to a family history of dementia cannot be accounted for by known genetic factors. Hence, we simply don't know. Maybe there are genetic factors that we don't know about, or maybe it's just the fact that you share the same house, the same meals, or something else that confers this increased risk of dementia. A very important category of risk factors for dementia are vascular risk factors. Vascular risk factors are those that are related to an increased risk of getting heart attacks and strokes, and include high blood pressure, diabetes, high blood cholesterol, and smoking. These vascular risk factors not only increase the chances of getting a heart attack or a stroke, but also increase the risk of getting dementia. So about a quarter of patients who have suffered a stroke will eventually develop dementia in the 6 months that follow the stroke. Now, it has been found that having a stroke not only increases the chances of developing vascular dementia, but also Alzheimer's disease. So one of the most important vascular risk factors is high blood pressure. The higher your blood pressure, the higher the risk of developing dementia. There is no magic number below which blood pressure has no further effect on risk. In other words, generally physicians are told to treat high blood pressure when the blood pressure is above 150 over 90. Recently, those numbers have been revised lower. But there is actually no magic lower number below which the risk of dementia is not increased by an increase in blood pressure. So the lower your blood pressure, the better off you are. It has also been noted that higher blood pressure may also be related to faster cognitive decline once dementia has taken hold. In other words, in people who already have dementia and whose cognitive abilities eventually keep on declining, those who have higher blood pressure have a quicker decline than those who have a lower blood pressure. Decreasing blood pressure may actually decrease the risk of dementia. There is some evidence that decreasing blood pressure with medication reduces the risk of dementia in otherwise healthy individuals. And pretty good evidence that it does so in patients who have suffered a stroke. Vascular risk factors and other risk factors for dementia is having high cholesterol. The evidence that high cholesterol is related to dementia somewhat less good than the evidence for blood pressure. There is mixed evidence that statins, a group of medication used to lower cholesterol, may also reduce the risk of dementia. We are still awaiting for conclusive data from clinical trials to know for sure whether lipid-lowering drugs decrease the risk of dementia. Another factor that plays a role in the risk of developing dementia in older age is socioeconomic factors. It has been observed over and over that lower educational attainment is associated with an increased risk of a dementia. That is, having completed primary schools is associated with higher risk of dementia than having completed a university degree. Also, higher complexity of the job held by an individual is associated with lower risk of dementia. That is, having held a job requiring complex decision-making in managing people and a business appears to favorably influence the chance of developing dementia even after retirement. After you retire, it actually seems that reading books or newspapers, writing for pleasure, doing crossword puzzles, playing board games or cards, participating in organized group discussions, and playing musical instruments decreases the risk of dementia later in life. Participating in leisure activities shows a dose-dependent effect on risk of developing dementia. That is, the more frequently you engage in these activities, the lesser the risk of developing dementia. Also, physical activity seems to play a role in decreasing the chances of developing dementia. Physical activity in middle and old age decreases the risk of developing dementia. In patients with dementia, small studies have indicated that increasing the physical activity level may slow cognitive decline. The size of this effect is small, but may be comparable to that of medications used to mitigate the effects and the symptoms of dementia in stricken individuals. Let me now pass on to an important study that actually is quite interesting since it relates your intelligence and cognitive abilities very early in life to your risk of developing dementia in old age. And this is the NAN study that actually, for its impact, deserved a cover page on Time magazine a few years back. The study, it's a study of cognitive changes in 678 elderly nuns living in Catholic convents in America's Midwest, mainly in the state of Minnesota and Wisconsin. The nuns that participated in the study agreed to undergo yearly assessments of their mental abilities. The nuns also agreed to donate brains for examination after death, thus providing the investigators the opportunity to examine the type of pathology that actually affected the brain of these nuns. One of the main publications that came out of this project, and that rightly so got quite a bit of publicity, is the one shown here, namely Linguistic Ability in Early Life and Cognitive Function and Alzheimer's Disease in Late Life. A seminal observation from the NAN study concerns the relation between early life cognitive abilities and risk of dementia in old age. Researchers were able to obtain from the archives of the convents the note that the nuns had written more than 40 years earlier. In this note, they needed to justify and explain their wish to join the religious order. These notes were assessed by the investigators. The conceptual and grammatical complexities of those writings were assessed and correlated with the risk of dementia and brain pathology in old age. So, what does it mean to assess the grammatical and conceptual complexity of these writings? And I think this is best captured by actually showing you two writings that illustrate quite well the difference between a writing that is poor in ideas and grammatical complexity, and one that is rich in idea and grammatical complexity. And these are from Sister A and Sister B. So Sister A wrote, "I was born in Eau Claire, Wisconsin on May 24th, 1930, and was baptized in St. James Church." A few sentences later, she wrote, "Two of the boys are dead." And finally, at the end, she wrote, "I prefer teaching music to any other profession." On the other hand, Sister B, who shows high conceptual and grammatical complexity in her writing, wrote the following: "The happiest day of my life so far was my first communion day, which was in June 1920, when I was but 8 years of age. And 4 years later, in the same month, I was confirmed by Bishop D.D. McGavick." A few sentences later, she wrote, "I visited the Capitol in Madison and also the mother house of the Franciscan Sisters of Perpetual Adoration at Duluth, which visit increased my love for Notre Dame, because it was and is Notre Dame. And finally, now I am wandering about in the Dove's Lane waiting, yet only 3 or more weeks to follow in the footprints of my spouse, bound to him by the holy vows of poverty, chastity, and obedience." So clearly, two very different write-ups. These write-ups were done when the two sisters were about 20 years of age, in their late teens, early 20s. And once, for all the sisters that are participating in the studies, their writings were assessed and their conceptual and grammatical complexity measured, then the investigators looked at the likelihood of the nuns developing dementia. And what they found that nuns who showed greater conceptual and grammatical complexity in their writings at age 20 were at lower risk of developing dementia after age 65 than nuns who showed lower complexity. Surprisingly, the brain of nuns who showed higher complexity in their writings also had healthier brains, that is, brains with less evidence of Alzheimer's disease, than the brains of nuns who showed lower complexities of idea and grammar. What are the implications of this study? Well, a prevalent hypothesis in the medical community is that higher intelligence decreases risk of dementia because it provides a greater cognitive reserve, does not fully account for the results. And the hypothesis is the following, is that if you're more intelligent and you're stricken by Alzheimer's pathology, you have more reserve to draw upon in order to continue function normally than a person who is less intelligent. However, there is no implication in that hypothesis that actually intelligence per se prevents Alzheimer's disease pathology. But that's exactly what the study had shown. Namely, that the correlation between the presence or absence of Alzheimer's disease pathology and early cognitive abilities suggests not only that intelligence protects against the clinical manifestation of Alzheimer's disease, but also that it may prevent or delay the onset of brain changes with age. So let me change tack for a second. What do we know about the prevalence of dementia in Gwinnett County? A study was conducted about 4 years ago about the incidence of dementia in England and Wales. This was a study conducted by an MRC Institute in Cambridge, which compared the frequency of dementia across 5 sites in the UK. And the 5 sites were in Gwinnett, Cambridge, Oxford, Newcastle, and Nottingham. Overall, the study enrolled something like 20,000 patients, or rather participants. And the expectation of the researchers who conducted this study is that Gwinnett County, which is known to have a higher prevalence of risk factor for dementia, should also have a higher prevalence of individuals with dementia than, for example, Cambridge. And the risk factors that I'm referring to are mainly vascular risk factors and socioeconomic factors. In Gwinnett County, we know that population in Gwinnett County tends to be less healthy than population in other parts of the country. There is a higher incidence of cardiac disease. There is a higher incidence of stroke. There is a higher incidence of diabetes related to obesity. Also, generally, individuals and the population in Gwinnett County has a somewhat lower socioeconomic status than, for example, Cambridge or Oxford. And hence, the expectation is that we should be experiencing higher rates of dementia than Cambridge or Oxford. However, the data don't show that. And here is the data that show the proportion of individuals affected by dementia in Gwinnett County. And when you compare it, for example, to the proportion of individuals affected by dementia in Cambridge, you see that actually it's no different, if anything, slightly lower. Actually, what the researchers who conducted the study found is that there was really no much difference between the 5 sites that were sampled. So that so we are facing a little bit of a conundrum. How come that in Gwinnett County, and again I misspelled it and I apologize, we don't have a higher prevalence of dementia than in other parts of the country? As I said before, Gwinnett County has a greater prevalence of risk factors for dementia, such as high blood pressure, smoking, stroke, lower educational attainment than in Cambridge, for example. Nevertheless, the risk for dementia is the same as in Cambridge. Why is that so? Well, one can put forward a speculative suggestion, that is that the high prevalence of bilingualism in Gwinnett County is protective and negates the adverse effects of vascular and other risk factors. Specifically, studies conducted in Canada have indicated that speaking 2 languages or more improves mental flexibility in young adults and is associated with a lower risk of dementia in older adults. This is the study I'm referring to, titled Bilingualism as a Protection Against the Onset of Symptoms of Dementia. In these studies, investigators actually looked at data from 288 patients seen at the local memory clinic because of cognitive difficulties. 184 patients were given the diagnosis of dementia. In these 184 patients, the age of onset of memory thinking and thinking difficulties was estimated during the clinical assessment. And data were also collected regarding the languages spoken by the patient, their educational and professional attainment. What did the data show? Well, the data showed that bilingual patients with dementia developed the symptoms of the disorder 4 years later on average than monolingual patients. This effect was not related to differences in educational attainment, which was actually lower in the bilingual patients, or professional attainment, which were similar in the two groups, namely the group of bilingual and monolingual patients. The investigators concluded that bilingualism is associated with a significant protection against dementia. So, what do risk factors tell us about dementia? The influence of a variety of factors on the risk of dementia, some related to early brain function, indicates that the brain is not a simple bystander in the face of an ongoing pathological process. Rather, its activity, as expressed by a person's intelligence, educational, and professional attainment, strongly influence age-related changes in memory and thinking abilities. The question then is how is intelligence related to brain activity, and how is brain activity related to dementia? Well, a study actually addressed at least the last part of this question, namely the part relating to the relation between brain activity and dementia. The study was published in the journal Neuroscience and is titled Molecular, Structural, and Functional Characterization of Alzheimer's Disease: Evidence for a Relationship Between Default Activity, Amyloid, and Memory. Sounds pretty daunting, but we'll try to explain what actually took place in this study. This study, brain patterns of metabolic activity in young adults, in the brain of young adults, were compared to brain patterns of amyloid protein deposition, which is a pathological hallmark of Alzheimer's disease, atrophy, that is brain tissue loss caused by amyloid deposition, and metabolic activity in older adults. The question asked was whether areas of the brain that shows highest metabolic activity in young adults are those most prone to injury from Alzheimer's disease pathology. And the answer to that question is yes. And this is the main figure of the paper that actually showed that. So what is shown here, and I'm sorry, but I cannot point to it, but so I'll have to jump. But what it shows here is a depiction of the brain. On top, the lateral surface of the brain. On the bottom, the medial surface of the brain. Those areas colored in blue represents area in a young person's brain that are most active. A person's brain doesn't show uniform metabolic activity, but rather there are certain parts of the brain that are much more active than others. And those are the ones that are actually colored in blue. Now, the investigators also were able to image in living patients the pattern of amyloid protein deposition, namely this abnormal protein that gets deposited in the brains of people suffering from Alzheimer's disease, and that is thought by some to be the cause of the disease. And what you can see is that the pattern of amyloid deposition, which for example involves the frontal lobes and retrosplenial cortex on the medial surface of the brain, and affects the frontal lobe, parietal lobe, and the temporal lobe on the lateral surface of the brain, closely matches the pattern of increased metabolic activity observed in a young person's brain. They also measure the degree of atrophy of the brain, namely the degree of tissue loss in the brains of people in whom amyloid deposition was found. And what they found is that actually the pattern of atrophy, again, closely matches the pattern of amyloid deposition and the pattern of increased metabolic activity found in the young person's brain. These areas of the brains were also the ones that actually show a decrease of metabolic activity in people with dementia. So, what is the conclusion from this data? Well, the conclusion is that most active brain areas are the ones that are most prone to develop Alzheimer's pathology. So the brain doesn't show, in healthy young adults, doesn't show a uniform pattern of activity, but rather there are regional variation in its rate of metabolic activity. These regional variations in metabolic activity actually reflect regional variations in neural activity. Namely, those areas that are most active in the young adults are also the ones where you find most neural activity, and are the ones where you actually find changes related to Alzheimer's disease in older individuals. The inference is that regions with most neural activity are those most prone to develop pathology. How can one reconcile this observation with the data relating intelligence and early cognitive abilities to risk of dementia? It's not obvious. Intuitively, one should expect that brains belonging to intelligent people should show higher metabolic activity than brains belonging to less intelligent people. I think that's what we would all expect intuitively. However, data from neuroimaging suggests otherwise. Intelligent people use less brain than less intelligent people when solving the same task. Thus, inter-individual differences in intelligence and cognitive performance seems to be mostly related to how efficiently one uses his or her brain rather than how hard. Speculative hypotheses can thus be put forward, namely that intelligence minimizes metabolic activity in the brain and hence delays the deposition of amyloid protein in the brain and the consequences of that deposition, namely brain atrophy and eventually a decrease in intelligence and cognitive abilities. Whether that is true or not remains to be seen. So, what comes next? Currently, we mostly do not have conclusive data to answer the question whether modifying risk factors changes risk. The expectation is that an answer will become available soon for vascular risk factors, since there are major financial incentives to big pharma to invest money into finding a possible positive answer to that question. They can sell drugs to decrease your risk of developing dementia. That's good for the business. Less clear is how to test experimentally the possibility that boosting intelligence and cognitive ability in early life may prevent or delay dementia onset. Moreover, which payer would stand to gain financially from making people smarter and hence have an interest in sustaining such research? Thanks, and I'll take questions now.
I'd like to know, in the study in Gwinnett, how far were the groups matched between? Yeah.
How were the groups matched?
In terms of other risk
They were matched by the recruitment criteria. The entry criteria for the study was that the person had to be of a certain age. There were no other recruitment criteria. And then the data were analyzed by age groups. So they were stratified by age group, but there was no other requirement, really.
So was it possible then that there were other risk factors in the sample that may have accounted for the difference that were
That's certainly
undetected?
possible, and that's always a concern with these type of studies that are observational studies. Data regarding risk factors were collected, but at least were not published in this particular study. So we don't know a whole lot about that. Eventually, that was sort of a moot point, I guess, because no difference was found across sites. So I guess the investigators or the reviewers of the article thought that there was not a relevant piece of information.
So I'm making a bit of an assumption that sleeping produces a lower metabolic activity than when one's awake. So I'm wondering whether the amount of sleep you have relates to your risk factor of getting dementia.
Good question. Yeah, I think there are different phases to sleep. And some phases probably exhibit the same degree of metabolic activity that is found in the waking brain. However, there are some phases of sleep, which is non-REM sleep, where there is a decrease in metabolic activity. I actually do think that there is evidence that people who sleep more tend to generally age better, and also that cognitive aging is better. So yes, absolutely, sleep as much as you can. Obviously, there are some conditions, like depression, low mood, that are associated in some cases with hypersomnia, increase in sleep duration. It is not clear that in that case, actually, sleep is protective, because depression by itself is probably to some degree a risk factor for dementia. At least there is an association.
If intelligence was, say, the attribution for Alzheimer's disease, what would you consider the repercussions to be associated with these findings? Could you predict, would there be a stigma or associated with people who are less
in other words,
intelligent?
you are asked, let me rephrase your question just to make sure that I got it right. You're saying if the chances of developing Alzheimer's disease depend on you being intelligent or less so, whether developing Alzheimer's disease would mean that you are not particularly bright to begin with. No, I don't think so. In other words, we are talking here about risk for one thing. There is always a chance that you will develop Alzheimer's disease. And this may be somewhat of a contentious issue, but if you remember that slide in which I showed the relation between the number of individuals stricken by dementia and age, there is some evidence there that eventually, if you wait long enough, everyone will be demented. If we were given the opportunity to live until we are 200, chances are that we will all be demented. Now, people take issue with that. Not everyone agrees with that statement. But there is really no evidence so far that this ever-increasing risk of dementia eventually stops at some age. So, no, I don't think so, because eventually we'll all be getting it if we live long enough.
Is there any study about people who has burnout disease with a lot of memory problem? Is there a risk factor for dementia for that?
For which disease, I'm sorry?
The burnout, when you're exhausted, burnout. You don't have that word
you
in
mean
English?
Something like chronic fatigue syndrome?
Yeah, something like that, yeah. Yeah.
Ooh, let me think about this for a second. Okay, well, very indirectly maybe. There is a suggestion that maybe more stress than fatigue, which is associated with hormonal changes, is also associated maybe with decreased neurogenesis in the hippocampus, which is the structure of the brain that allows you to store new memories. And neurogenesis is the process which defines the creation of new neurons. It seems like the hippocampus may be one part of the brain where new neurons actually come about throughout life. The rest of the brain doesn't seem to be endowed with that property. And it seems that actually stress has a negative effect on neurogenesis, and therefore may impair your ability to form new memories or to retrieve memories. Whether that actually is also a risk factor for Alzheimer's disease is not something I'm aware of, but it may be so.
I read an article about light affecting patients with dementia. Are there any studies from across the world that suggest that people in Mediterranean regions do better than darker countries?
Well, dementia is frequently associated with delirium and another condition called sundowning, where what is observed is that the mental abilities of a person fluctuate in synchrony with the day-night cycle. So that people are generally brighter, more alert early in the day than toward dusk. Then if that circadian pattern, that pattern that sort of changes with the day-night cycle, can be modified by bright light, for example. And it's possible that some of these effects of light are effects on phenomena like sundowning. I don't think it's a cure for dementia, but it may ameliorate this particular aspect of dementia, namely the fact that people actually who suffer from dementia exhibit these intraday variations in their mental abilities. So it has been shown, for example, in hospitals that providing light in a dark room may improve the patient's mental status. These seem to be, though, transient effects. They don't seem to be sustained. So it's not a cure for dementia, but it may improve some of the symptoms, at least transiently.
In one of your inferencings, you made mention about the efficiency of using the brain as compared to putting so much pressure on the brain. How would you be able to measure that?
To measure, I'm sorry, what
Efficiency.
exactly? To measure?
Efficiency of using the brain.
Efficiency. Oh, I see. Well, one way it has been measured, or it has been compared, is, for example, asking people of varying cognitive abilities to perform the same task in a scanner and measuring the changes in metabolic activity experienced by people performing that task. What is generally found is that people who are better at doing the task, who have greater cognitive abilities, actually have less activation, less increase in metabolic activity than people that are less able to perform the task. So the other thing that is also observed, for example, in older individuals, is that when you ask them to speak, for example, in younger adults, generally the left side of the brain tends to be activated. In older adults, their patterns becomes more symmetric, and now also the right hemisphere becomes activated. So it seems that with aging, this efficiency goes down. And it's also related to how good your mental abilities are.
If I recall the first studies on bilingualism affecting executive function in healthy individuals, the finding was that it was the learning of two languages from infancy at the same time.
Right.
That was the key thing that was critical for not simply having learned a second language at some time. Is that also true for the dementia study?
For the dementia study, the definition used for bilingualism is the fact that early in adult life, people were using two languages. But early in adult life is, around age 20. So there was no requirement that people were actually learning the language early in their infancy or as children. So there was no such requirement.
There's certainly countries where bilingualism is much, in the Scandinavian countries, is much more of extremely high incidence of bilingualism compared to, say, the United States, where the incidence is negligible.
And indeed, people in Scandinavia do better in school than people in the United States.
Yeah, so is there a difference in incidence of dementia?
Oh, that's a good point. I'm not aware of that. The problem is that when you come to compare studies from different countries, one of the main problems has been that the definition of dementia has varied across sites. So even within the United States, you get wide variations in the estimates of the prevalence of dementia. And this mostly comes down to what is your definition of dementia. So what we are really waiting for is, using standardized ways to do that. But I think so far that has been kind of lacking. So comparing across countries is certainly an interesting thing to look at. But while we have data from a number of countries, those data cannot really be compared. Thank you very much.